Welcome back to the deep dive. Today we're tackling a really significant procedure, carotid endarterectomy, or CEA for short.
Yep, CEA. It's a surgery with quite a history, actually, and it's fundamentally about preventing stroke, which is, a huge deal.
Absolutely. And we've got this detailed chapter to guide us, really digging into CEA.
All right, we'll cover why it's done, how the surgery actually works, the different techniques, and importantly, what potential problems can crop up.
So our mission for you, the listener, is to make sense of all this. We want to pull out the key concepts, the evidence, maybe even some surprising bits.
Exactly. Give you that solid understanding without getting totally lost in the weeds.
Okay, so let's jump right in. To really get why CEA is important, we need to talk about stroke itself. The numbers are pretty sobering.
They really are. In the U.S. alone, we're looking at, at least 750,000 strokes every single year.
Wow.
And a really significant chunk of those lead to serious long-term disability or even death. It's a major public health issue.
No question. And a big part of the problem, especially for ischemic strokes, the ones caused by blockages, comes from the neck, right?
That's right. Atherosclerosis, basically plaque buildup in the carotid artery in the neck, it's estimated to be responsible for something like 20% of those ischemic strokes.
So 1/5, that's significant.
Definitely. And how that plaque actually causes the stroke is interesting. It's usually one of a few ways.
Okay.
You can get atheroembolization, tiny bits of that plaque breaking off and heading straight to the brain.
Little missiles, essentially.
Kinda, yeah. Or you can get thromboembolism. A blood clot forms right there on the rough surface of the plaque, then that breaks off or blocks the artery.
Okay, so debris or a clot?
Or, less commonly, the narrowing just gets so severe that not enough blood can get through. Sort of a low flow situation.
Right, makes sense. So we see the danger.
Yeah.
Why CEA then? When do doctors start thinking, okay, surgery might be the answer here?
Well, the guidelines are pretty specific now, mainly based on how narrow that internal carotid artery is, the stenosis.
And whether the patient has had symptoms.
Exactly. For patients who are symptomatic, maybe they've had a TIA, a mini stroke, or a small stroke, and their stenosis is between 50% and 99%. CEA is generally recommended. That's according to the Society for Vascular Surgery guidelines.
Okay, 50 to 99% for symptomatic patients.
Yeah.
What about people who have significant blockage, but maybe luckily haven't had any warning signs? The asymptomatic group.
Right. For asymptomatic patients, the bar is a bit higher. Usually we're looking at 70% to 99% stenosis.
But there are conditions.
Yes, crucial ones. The risk of the surgery itself, having a stroke or dying from the procedure, needs to be low, typically less than 3%.
Yeah.
And importantly, the patient needs to have a decent life expectancy, say at least 3 to 5 years, to really get the long-term preventative benefit.
That makes sense. You're weighing the immediate risk against the future benefit.
Precisely. And we should also mention there's an alternative sometimes.
Yeah.
Carotid artery stenting, or CAS. It fits in specific situations.
I'll probably touch on that more later. What if the blockage isn't that severe, say less than 50%, but the patient has had symptoms?
Yeah, for those symptomatic patients with less than 50% stenosis, the main approach is typically medical therapy. Medications.
Yeah, I sense a but.
Well, medicine's always evolving, isn't it? There's some newer research looking at specific situations, even with less than 50% stenosis, where the plaque itself looks really unstable on advanced imaging, like it's bleeding inside.
Intraplaque hemorrhage.
That's the term. In those rare cases, some are starting to consider if CEA might still have a role. But generally, medicine is the first line below 50%.
Okay, so let's say a patient fits the criteria, CEA is being considered. What happens before they even get to the operating room? What's the workup like?
Good question. The starting point is almost always a duplex ultrasound. It needs to be done in a good, accredited vascular lab.
This sound wave thing.
Yep. Non-invasive, gives us a really good look at the blood flow, helps measure that stenosis. But sometimes, if the blockage looks like it's really high up in the neck...
Near the skull.
Exactly. Or if the ultrasound picture just isn't totally clear, then we might move on to other imaging. CTA, computed tomographic angiography, or MRA, magnetic resonance angiography.
Do they all show the exact same thing? Like if you get 70% on ultrasound, will CTA show 70% too?
Not always. That's a key point. There's some suggestion that CTA might sometimes underestimate the blockage slightly, and MRA might overestimate it.
Interesting.
It's why, even though some very experienced centers might proceed just based on a high-quality duplex, many surgeons feel more comfortable confirming those findings with a second test. like CTA or MRA, before scheduling surgery. The benefit of CEA is so tied to that stenosis percentage, you want to be sure.
Double checking makes sense. What about just the patient's general health? How does that play into the pre-op phase?
Oh, absolutely critical. We need a thorough medical evaluation. The AHA classifies CEA as an intermediate cardiac risk procedure.
Meaning heart issues are a concern.
They are. So we need proper risk stratification. That might mean a cardiac workup for some patients, and we definitely need good medical management leading up to surgery.
Like what?
Controlling blood pressure is key. Statins are usually started or continued. They help stabilize the plaque and lower cholesterol. And antiplatelet therapy, like aspirin or clopidogrel, to prevent clots.
What about beta blockers? I hear about those a lot with surgery.
Yeah, it's a bit nuanced. If a patient is already on them long-term for other reasons, they're usually continued. But starting them just before CEA for short-term benefit isn't generally recommended anymore based on the latest evidence.
Got it. Okay, patient's ready, medically optimized. Let's head into the OR. Anesthesia first. What are the options?
Right. You've got a few choices. General anesthesia, where you're completely asleep. Regional anesthesia, which is usually a nerve block in the neck. You're awake, but the area is numb. Or even just local anesthesia, numbing only the incision site.
Does it matter which one you get for outcomes?
Interestingly, studies haven't shown a big difference in major outcomes, like length of hospital stay based on anesthesia type. There was some thought that regional might be better for the heart during the surgery, but that hasn't consistently translated into fewer heart attacks afterwards. Each has pros and cons.
Such as?
Well, general anesthesia means the patient is totally still, no discomfort. Regional might offer that theoretical cardiac stability, but, the patient's awake, could be anxious, and there are rare risks like seizures from the block.
And local.
Local, especially combined with regional sometimes, has a really key advantage for something we call selective shunting.
Explain shunting.
We'll get deeper into it, but basically it's putting a temporary tube in the artery to keep blood flowing to the brain while we clamp it to work. With local or regional, the patient is awake.
So you can see if they're okay.
Exactly. We can monitor their neurological function directly. If clamping the artery causes any change, any sign the brain isn't getting enough blood, we know immediately and can put that shunt in selectively. It's very efficient.
That's clever. Real-time feedback. Okay, what about just getting the patient set up on the table? Positioning.
Also, really important for access. We usually put a roll under the shoulders, a padded ring under the head to gently extend the neck. If the patient's awake, sometimes a Mayo stand over the head helps create space under the drapes.
To avoid feeling trapped.
Yeah, helps with claustrophobia. Then the table is tilted and rotated to bring the side of the neck we're operating on right up into view for the team.
Okay, patient positioned, anesthesia working. Time for the cut. How do surgeons make the incision?
Two main ways, typically. The most common is a longitudinal incision running along the front edge of that big neck muscle, the sternocleidomastoid.
The one that pops out when you turn your head?
That's the one. We can angle it back near the jaw if we need higher access. The other option is an oblique or transverse incision following a natural skin crease, usually a bit below the jaw angle.
Does it matter which one?
Both work well. The choice might depend on surgeon preference or exactly where the blockage is. They can both be adjusted as needed during the surgery.
Incision made. Now the careful part, getting down to the artery itself.
Extremely careful. The key here is gentle dissection. You absolutely want to avoid poking or squeezing the carotid artery too much before you clamp it.
Because you could knock plaque loose.
Precisely. That's how you can cause a stroke right there on the table. So it's meticulous work identifying key landmarks.
Like what structures?
You need to find and protect the external jugular vein, the facial vein crossing over, the vagus nerve, which usually runs right with the artery. Then you carefully get control of the common carotid artery, usually with a soft silicone loop. Finding the ansa cervicalis nerve helps guide you around the bifurcation where the artery splits and helps avoid the hypoglossal nerve.
The tongue nerve.
Yep. Then control the branches. Superior thyroid artery, external carotid artery. Finally, expose the internal carotid artery beyond the plaque, all while trying not to disturb the carotid body right in the fork, which can mess with blood pressure.
Sounds like navigating a minefield.
It requires focus, absolutely. Once it's all exposed and controlled, then you can actually do the endarterectomy, remove the plaque.
And how's that done? You mentioned two main techniques.
Right. The first is what we call conventional endarterectomy. This is probably the most common.
How does it work?
You make a cut, an arteriotomy, vertically along the artery, extending from the common carotid up onto the internal carotid, right over the plaque.
Okay.
Then you carefully peel the plaque out. There's a natural plane between the inner layers and the outer wall of the artery. Getting a clean removal, especially a smooth end point where the plaque stops distally in the internal carotid, is critical.
And then you close the cut.
Yes, but usually not by sewing it edge to edge. We almost always close it with a patch.
A patch, like for jeans.
Sort of. It's a piece of material, could be the patient's own vein from their leg, the saphenous vein, or a synthetic material like PTFE, Dacron, or bovine pericardium. This patch widens the artery at the closure site.
Why widen it?
Reduces the chance of it narrowing down again later, stenosis. Before the final stitches go in, we flush everything out carefully to remove any tiny debris or air bubbles.
Okay, that's conventional. What's the other main way?
That's evergin endarterectomy. It's a different approach.
How so?
Instead of cutting along the artery, you actually cut across the bifurcation, either partially or completely separating the internal carotid from the common carotid.
You cut it off.
Temporarily, yes. Then you can sort of roll or invert the cut end of the internal carotid inside out, like cuffing a sock. This exposes the plaque, and you can peel it off the inside wall.
Ah, I see. Then sew it back on.
Exactly. You then reattach the internal carotid to the common carotid with a direct anastomosis, sewing the ends together.
What are the pros and cons of eversion versus conventional?
Well, eversion can sometimes be quicker, the sewing part at least, and some data suggests maybe a lower risk of stenosis long-term because you don't have that longitudinal suture line, plus no need for patch material.
Sounds good. Downsides?
It can require a bit more dissection in the neck. Using a shunt routinely is trickier with eversion, and seeing that far endpoint inside the internal carotid after you remove the plaque can be harder. So checking the repair afterwards, a completion study, becomes maybe even more important.
And conventional.
Conventional gives you great direct vision inside the artery, makes shunting easier if you choose to do it. It's very versatile.
So is one definitively better?
Big studies like the Everest trial haven't really shown a major difference in the most important outcomes, stroke or death. Some analyses hint eversion might have lower stenosis rates, but conventional with patching is still considered the standard of care by many.
Okay. Now, you mentioned getting access can be tricky if the blockage is high up. Tell me more about those high carotid lesions.
Yeah, that definitely ups the challenge. If the bifurcation, where the common carotid splits, is way up high near the jawline or base of skull,
C2 level?
could be C2, even higher sometimes. It just makes getting your instruments in there and seeing what you're doing much harder, increases the risk of nerve injury too.
How do you know beforehand if it's going to be high?
Preoperative imaging is key. CTA is particularly good because it shows the bony anatomy alongside the arteries, so you can see exactly where that split is relative to the jaw and spine. That lets you plan.
Plan what? What tricks do surgeons have for high access?
Several maneuvers, sometimes just using nasotracheal intubation, the breathing tube through the nose, helps. It lets the jaw move forward a bit more.
Buys you some space.
Exactly. We might also need to divide the posterior belly of the digastric muscle, which runs through that area. But you have to be so careful doing that. Identify and protect the nerves nearby, hypoglossal, spinal accessory, glossopharyngeal.
Nerves everywhere up there.
Oh, yeah. In tougher cases, you might resect the styloid process, that little pointy bone coming down from the skull base. That can really open things up.
Removing bone.
A small piece, yeah.
Yeah.
Another option, more involved, is anterior subluxation of the mandible. Basically working with other specialists, like oral surgeons, to temporarily shift the lower jaw forward during the surgery requires planning.
Wow. These sound like major interventions just to get access.
They can be, but sometimes necessary for a safe endarterectomy in those high lesions. It highlights the complexity.
Definitely. Okay, let's shift back to something you mentioned earlier, protecting the brain during the surgery itself. Shunting.
Right, cerebral protection. Hugely important because you have to clamp the carotid artery temporarily to remove the plaque.
Cutting off blood flow to the brain.
To one side, yes. And while most people tolerate that okay because of collateral circulation from the other side or other vessels, some don't. That's where shunting comes in.
So the options are: don't use a shunt ever, use one always, or use one sometimes.
Pretty much. Routine non-use, routine shunting, or selective shunting.
We talked about selective shunting with local anesthesia monitoring the await patient. How do you do it if the patient's under general?
That's where those monitoring techniques come in. You can measure the stump pressure, the back pressure in the internal carotid when it's clamped.
What does that tell you?
Historically, a low pressure, say below 50 millimeter Hg, was thought to mean higher risk, suggesting a shunt was needed, but it's not perfectly reliable. Lots of false positives and negatives.
Okay, what else?
EEG, electroencephalography monitoring brain waves, or SFE, somatosensory evoked potentials. They look at electrical activity.
Are they reliable?
EEG can be quite sensitive, maybe too sensitive sometimes, showing changes that aren't clinically significant. SFPs can be less reliable during this specific surgery.
Any other methods?
Transcranial Doppler, TCD. Ultrasound through the skull to measure blood flow speed in brain arteries. Its unique thing is detecting micromubbly tiny bits breaking off.
That sounds useful.
It is for that, but its accuracy in predicting actual ischemia, lack of blood flow needing a shunt, has been questioned.
So awake monitoring seems the most direct way to be selective.
Arguably, yes, because you're seeing the direct neurological consequence of clamping. And studies show awake CE generally leads to the lowest rates of actual shunt use.
So what's the bottom line on shunting strategy? Is routine better? Selective?
It's still debated. A big meta-analysis basically found similar stroke rates with routine shunting compared to well-executed selective shunting, like using awake monitoring or EEG stump pressure combined.
But maybe not TCD alone.
Right. Selective shunting based only on TCD seemed to have slightly worse results in that analysis.
So what do surgeons actually do?
It often comes down to surgeon preference and experience. The argument for routine shunting is consistency. You're maintaining flow, reduces anxiety, prevents clamping ischemia.
Makes sense.
The argument against it is, well, placing a shunt isn't risk-free either. It's a foreign body, can injure the artery, maybe cause emboli itself. Why do it if the patient doesn't strictly need it?
And selective shunting still involves that test clamp.
Exactly. Even the brief clamp to check if a shunt is needed carries a tiny risk. So there's no perfect answer. The author of our source material, for instance, states a preference for routine shunting in their practice for that consistency.
Okay, complex decision. Let's move to closing the artery. You said patching is key.
Yes. Patch closure is definitely superior to just sewing the artery shut directly primary closure. Significantly lower risk of restenosis.
You mentioned different patch types, vein versus synthetic.
Right. Saphenous vein from the leg works well, integrates nicely, but you need another incision to harvest it, risk of wound issues there, and you use up a vein that might be needed later for heart or leg bypass.
And a rare risk of rupture.
Very rare, but yes, especially if you have to use a smaller vein from the ankle. There are studies looking at vein diameter and risk.
What about the artificial ones? PTFE, Dacron?
PTFE, Dacron, bovine pericardium, they're readily available, no harvest site issue. They work very well too. Large studies comparing vein patches versus synthetic patches haven't really shown one is clearly better than the other overall for stroke or death.
But patching itself is better than not patching.
Overwhelmingly, yes. Compared to primary closure, patching significantly improves outcomes. It's become a quality benchmark for CEA.
Is primary closure ever done?
Very rarely. Maybe if the artery is unusually large. There was one study suggesting it could be okay with meticulous microvascular technique, but it's not standard practice. Patching is the norm.
What about that idea of selective patching? Only patching some patients?
Some surgeons do that. They might decide based on how big the artery looks after the plaque is out, or if the patient has risk factors for restenosis like being female, a smoker, or having high cholesterol. If the artery seems wide and risks are low, they might opt for primary closure. But again, routine patching is more common.
Okay, artery closed, patch in place. How do you make sure the repair is good before finishing up?
Completion studies. Doing an assessment right there in the OR.
What kind of assessment?
Usually using ultrasound, either continuous wave Doppler or more commonly now, intraoperative duplex ultrasound. Gives you a picture, shows blood flow. You can also do intraoperative angiography injecting dye, but ultrasound is often preferred.
What are you looking for?
Technical defects. Maybe a little ledge or flap inside the artery where you stopped peeling the plaque, an intimal flap. Or maybe a narrowing caused by a stitch. Duplex is quite sensitive for picking these up.
Do you have to fix every little thing you see?
That's the debate. Not every tiny irregularity is going to cause a stroke, and going back in to revise it carries its own risks. But if there's a significant defect, especially at that distal endpoint in the internal carotid, you'd want to fix it.
And he said this is particularly important for eversion endarterectomy.
Yes, because with everversion, your direct view of that final endpoint inside the artery is more limited compared to the conventional technique. So doing a completion study gives you that extra reassurance the transition is smooth.
Right. Okay, despite all this care, sometimes strokes still happen around the time of surgery. How are those managed?
Yeah, perioperative stroke, it's the most feared complication. The causes usually fall into three buckets: thrombosis or embolization, clot or debris, clamping ischemia, brain didn't tolerate the temporary lack of flow, or hemorrhage, bleeding into the brain. Early recognition and quick action are vital.
What if you suspect something during the operation under general anesthesia?
Okay, if there's a concern intraoperatively, maybe monitoring changes or something doesn't look right, the first thing after closing is often to wake the patient up right there for a quick neuro exam.
Seriously? In the OR?
If a deficit is suspected, yes. If it's confirmed, you might need to reopen the incision immediately. Check flow with Doppler, maybe do an intraoperative duplex or angiogram.
Kid for what?
A clot at the surgical site, a kink, a flap, something you can potentially fix right then and there. If you find a clot, you'd perform a thromboembolectomy, try to remove it.
What if the artery looks fine, but the patient still has a deficit?
Then you'd suspect either an embolus that traveled further up into the brain, or maybe ischemia from the clanting period. Management then becomes more medical blood pressure support, maybe considering clot-busting drugs or endovascular clot retrieval if the center has that capability quickly available.
And if the stroke happens after surgery, back in recovery.
Speed is still critical. First step, immediate duplex ultrasound. Is the operated artery open or blocked?
If it's blocked.
Back to the OR, urgently. Re-exploring to restore flow, ideally within an hour or two, gives the best chance of reversing the deficit.
If the duplex shows the artery is open,
Then you need a head CT right away. Rule out bleeding in the brain, a hemorrhage,
and if the CT is clear too, no bleed.
then usually an angiogram. Look more closely for subtle issues at the surgical site or more likely an embolus higher up in the brain's vessels. Depending on what you find and where, options might include catheter-based treatments like thrombolysis or mechanical thrombectomy.
A very structured, urgent approach.
Has to be. Time is brain.
Let's shift to the why, the evidence. What did the big trial show about CEA's effectiveness?
The evidence is really strong, especially for certain groups. First, symptomatic patients, those who've had TIAs or strokes. The NASCET trial was huge. It showed CEA dramatically reduced the risk of future stroke compared to just medical therapy, both for high-grade stenosis, 70-99%, and moderate grade, 50-69%.
So clear benefit for symptomatic patients with significant blockage.
Absolutely. Later trials like CREST and ICSS compared CEA to stenting, further confirming CEA's role.
What about the asymptomatic folks, the ones without prior symptoms? That seems more controversial.
It is more debated because their baseline risk of stroke is lower to begin with. But two major trials, ACAS and ACST, did show a benefit for CEA in reducing long-term stroke and death risk in asymptomatic patients with significant stenosis, usually 60%, compared to medical therapy alone.
But there's a catch.
The catch is weighing that long-term benefit against the upfront risk of the surgery itself. The stroke death rate from the operation in those trials was around 2–3%.
So you need to prevent more strokes long-term than the surgery causes up front.
Exactly. And medical therapy has gotten much better since those trials were done. Better statins, blood pressure control, antiplatelets. So the benefit calculation for asymptomatic CEA is something patients and doctors need to discuss carefully today. It's not automatic.
Makes sense. Do these trial results hold up in the real world outside of carefully controlled studies?
Generally, yes. Lots of studies looking at large hospital databases and population data show that the low perioperative risks and good long-term outcomes seen in trials are achievable in routine practice, especially at experienced centers.
Like the author's institution.
Right. Places like MGH, the Author Center, consistently report very low complication rates, often below 1% for stroke death. So shows CEA can be done very safely and effectively when done well.
Okay, but complications can happen. We need to talk about the risks. What are the main ones?
Well, cardiac complications are still a major one. Heart attack is a leading cause of death after CEA.
Because the plaque is often elsewhere, too.
Exactly. Carotid disease often means coronary artery disease, too. But thankfully, with better preoperative screening and management, the rates of major cardiac events have come down significantly over the years.
What else? Nerves.
Cranial nerve injury, actually the most common neurological complication after CEA. Reported rates vary, maybe 5% to 20%.
That sounds high.
It does, but the good news is most of these are temporary. They usually resolve.
How do the nerves get injured?
Usually from retraction during surgery, maybe some bruising or stretching, sometimes from electrocautery used to stop bleeding or getting caught in a stitch. Reoperations are higher risk.
Which nerves are most commonly affected?
The hypoglossal nerve, CN12, is probably the most frequent. It controls tongue movement. Injury causes the tongue to deviate towards the injured side when stuck out, maybe some weakness.
Noticeable.
Usually temporary, but can affect speech and swallowing a bit initially. We try to identify and protect it carefully.
Okay, who else is at risk?
The vagus nerve, CNX, specifically its recurrent laryngeal branch. Injury there causes hoarseness, maybe a weak cough.
Voice changes.
Yep. Another branch, the superior laryngeal nerve, can affect voice pitch and endurance, sometimes subtle swallowing issues. The facial nerve, CNF, the marginal mandibular branch, can get stretched, especially with transverse incisions. Causes a temporary droop of the lower lip, mostly cosmetic.
Any others?
Less common are injuries to the glossopharyngeal nerve, CN-narix, causing swallowing problems, or the spinal accessory nerve, CNS, leading to shoulder weakness or pain. And very commonly, patients get numbness around the earlobe, jawline, and upper neck from stretching or cutting small cutaneous sensory nerves like the greater auricular. Usually minor and improves over time.
Lots of potential nerve issues. What about blood pressure problems after surgery?
Hemodynamic instability, yeah, pretty common right after. You can get hypotension, low blood pressure, often with a slow heart rate, probably from resetting the baroreceptors in the carotid sinus. Usually responds to fluids, maybe some medication like phenylephrine.
And high blood pressure.
Hypertension is also common, especially if the patient was hypertensive before surgery. Again, maybe baroreceptor related, maybe hormonal changes, usually settles within 24 hours, might need IV meds like nitroprusside initially.
I've heard of something called hyperperfusion syndrome.
Cerebral hyperperfusion syndrome, thankfully rare but can be serious, usually happens a few days after surgery.
Symptoms.
Can range from severe headache to seizures, confusion, even bleeding into the brain, hemorrhagic stroke. It seems linked to suddenly restoring normal flow to a brain that was chronically used to low flow. Patients with severe blockage on the other side might be at higher risk. Strict blood pressure control is crucial to prevent and manage it.
Scary. Any other complications to mention?
Infections are rare, mostly minor wound infections. Patch infections are exceedingly rare, but serious if they happen. Bleeding or hematoma at the incision site can occur maybe in 1–3% of cases, often related to anticoagulation. Might need drainage. And finally, recurrent stenosis.
The artery narrowing again later.
Exactly. Happens in maybe 5–20% over the years. Early on, first year or two, it's often intimal hyperplasia scar tissue buildup. Later on, it's usually new atherosclerosis.
Does it always cause symptoms?
No, thankfully symptomatic recurrence is much lower. Risk factors include being female, smoking, high cholesterol. Patching definitely reduces the risk compared to primary closure.
Can you operate again if it narrows significantly?
You can do a repeat CEA, but it's technically harder because of scar tissue. Higher risk of nerve injury, bleeding. Sometimes carotid stenting is considered as an alternative for recurrent stenosis, though results compared to redo surgery are mixed.
Okay, that's a comprehensive list of potential issues.
Yeah.
Are there specific patient groups where the considerations are different?
Yes, definitely. Patients with combined carotid and significant heart disease needing bypass surgery, CABG, present a challenge. Do you fix the carotid first, then the heart? Fix the heart first. Do both at the same time.
What's the answer?
Still debated. Different centers have different protocols. Stage CEA before CABG is common. Simultaneous surgery has risks, but avoids two separate procedures. Stenting the carotid before CABG is another strategy being studied. No single best way for everyone.
What about age? Is CEA too risky for very elderly patients?
Actually, the evidence suggests CEA can be done quite safely in octogenarians and even nonagenarians, provided they're otherwise reasonably fit. Age alone isn't necessarily a reason to avoid surgery if it's indicated.
Gender. Does it matter if the patient is male or female?
Data's a bit conflicting. Some early trials suggested women might benefit slightly less from CEA for asymptomatic disease, but other large studies haven't shown significant outcome differences. It's still discussed.
And race.
Also, conflicting data. Some database studies suggested higher risks for African American or Hispanic patients, possibly related to access to care or maybe surgeon volume differences. Other studies within specific systems like the VA have shown similar outcomes. More research needed there.
Any other unique situations?
A few interesting ones. We mentioned symptomatic patients with less than 50% stenosis, but with unstable plaque features like intraplaque hemorrhage, seen on MRI CEA, might be considered there in rare cases. Carotid webs, these sort of fibrous shelves in the artery, often seen in younger patients, especially women and African Americans, causing stroke without major stenosis, CEA or stenting can treat these.
What about limb-shaking TIAs?
Yeah, rare symptom. Shaking movements in an arm or leg triggered by standing up or exertion due to severely low blood flow from carotid disease. CEA or stenting is the treatment, but these patients might have a slightly higher risk of hyperperfusion issues afterwards.
Can you do surgery on the external carotid artery?
Yes, external carotid endarterectomy, ECA endarterectomy, is sometimes done, usually only if the internal carotid is completely blocked, but the external carotid has significant stenosis and is thought to be causing symptoms, like emboli to the eye or brain via collateral pathways, not done for asymptomatic ECA disease.
What if someone had radiation to their neck, say, for cancer, and then develops carotid stenosis years later?
Radiation-induced carotid disease, it's a known late effect. The stenosis can be in unusual locations, and the tissues are often very scarred and fibrotic from the radiation, making surgery technically challenging. Conventional CEA is often still possible, sometimes needing bypass or just patch angioplasty. Outcomes seem better with surgery than stenting in this specific group.
One last thing, does it matter where you get the surgery done or who does it? Volume.
Yes, the evidence here is pretty consistent. Meta-analyses show lower stroke and death rates for CEA performed in high-volume hospitals and by high-volume surgeons.
What counts as high volume?
The exact number is debated, but thresholds like maybe 70, 80 CEAs per year for a surgeon have been suggested. It's likely not just the surgeon's skill, but also the whole hospital system, the team, the protocols. Experience matters.
Makes sense. Okay, as we wrap up, what's the big picture takeaway on CEA? Where does it stand today?
Well, even though it was first done around 70 years ago, CEA remains a remarkably effective and really important treatment for preventing stroke in the right patients. It's still the benchmark, the gold standard, that newer treatments like stenting are compared against.
And surgeons have gotten very good at it.
Vascular surgeons have really risen to the challenge, consistently meeting or exceeding the safety guidelines established by those major trials. It's a surgical success story, really.
Definitely. So to recap for everyone listening, CEA is crucial for stroke prevention in patients with significant carotid narrowing, especially if they've had symptoms. It's complex surgery, lots of technical details. Brain protection is key.
Right, and the evidence supporting it is strong, but like any surgery, there are risks and complications to understand. Patient selection is critical.
Which leads to maybe a final thought for our listeners to chew on.
Yeah, think about this. We have this proven surgical procedure, CEA, with decades of data. And then we have these rapidly evolving, less invasive endovascular options like stenting. In this landscape, how do we make sure the right patient gets the right treatment?
What questions should patients be asking?
Exactly. What should you ask your doctor to understand why CEA, or maybe stenting, or maybe medical therapy alone, is being recommended for you? How do you navigate those options?
That's a great point, a really important conversation to have. If you want to explore the studies and guidelines we touched on, definitely look them up.
And remember, talk to your own doctor about how this information applies to your personal situation.
Absolutely. Thanks so much for joining us on this deep dive into carotid endarterectomy.